Дорогие коллеги, прошу.
Dear colleagues, please be kindly seated. We would like to continue our deliberations, and we have the next session of our conference. It's dedicated to the diagnostic methods. We'll have another coffee break, so please be seated. And we have the first speaker by Victor Savella on the CT, computer diagnostics. Let's get started. Good afternoon, dear colleagues. I hope you had a nice coffee break. The coffee was good and it's good for networking, but please come back. I'm starting. Dear colleagues, here is my presentation on the following topic. CT for acute chest and abdominal injuries. How do we do this? Initially, we do a native examination. As a rule, our patients are severe, and we examine 5 zones, including head, neck, thoracic part, abdominal part, and pelvic. After that, we identify the pathologies, and then upon indications, we do a CT angio, and we inject contrast 100 milliliters, speed of injection 4 milliliters per second, and we use Hall's filter in our aortic arch area. We start from Velicium circle, and we end with symphysis. We do several phases, arterial, venous, and then we do a redundant or delay phase if we have indications for the traumas in urinary tract. If we have fractures in pelvic area, we have to do CT and cystography. Is it always that we need to do CT angio? This is an example. This is a combined trauma in thoracic part. We see rupture of lungs, and we see cavity formation, air cavity formation. And here it was not necessary to do CT angio. Same way in the next case, we did a native CT, and we see the trachea rupture. It was ruptured from bronchi in bifurcation area, and hemomediastinum and premiediastinum. And we see infusella of soft tissues. In the next examination, when we did the native CT, it's the next patient, we see a hematoma in pseudostenium to both cavities. When we do angio, we can differentiate a traumatic dissection of aorta in the descending part of aorta, and we can see a formation of pseudoaneurysm. It was decided to put a stent graft. You can see here is the stenting, and this is a control angio. The position of the stent graft is satisfactory. Next patient had a closed combined wound. We can see a hematoma in periosteum, and we see hematothorax. We see extravasation as well, which shows that there is an ongoing hemorrhage. This is a closed trauma in abdominal part. When we did absorb X-ray, we saw the loss of differentiation. We see an indication for angio. Then we do the CT angio. We see the extravasation of contrast substance beyond the trunk, and we can see the signs of ongoing hemorrhage. It was verified morphologically too. This is another examination of another patient. Hemoperitoneum is always challenging. What to do with a patient? We can say the following. A patient who has unstable hemodynamics and he has hemorrhage in abdominal area is a candidate for urgent laparotomy. If the hemodynamics is stable and we have hemoperitoneum according to ultrasonic study and he has a complicated clinical picture, he has to go through CT angio. This is native CT. We see blood in hemorrhage in abdominal area. We need to do CT angio. This is indication for CT angio. This is a compression fracture of the second vertebra. We see traumatic dissection and aortic rupture. It was confirmed when we did autopsy. You can see two sections of abdominal aortic rupture. This is a combined trauma, polytrauma. Initial visualization shows the fractures of 3 ribs on the right, and this is an almost direct indication for liver failure and liver trauma. We see also hemorrhage and blood in here, and here is liver. We do CT angio on the liver, and we clearly can visualize a large rupture in the right lobe of the liver, and then we can see a hemorrhage in the area of kidney in abdominal and periabdominal area. Since CT and angio helps us not only to diagnose and to describe the traumatic area, but also it helps us to assess the efficiency of treatment and restoration processes, including the ones in liver. This is a process. This is a patient with a combined polytrauma rupture liver. 9 days later, we do the CT. We see the hematoma got smaller, the rupture contours became sharper, and later on, we see that the rupture area is almost gone. We see some small outlets here, and this witnesses to the fact that we have a liver regeneration and the patient is being healed. Well, we did a dynamic follow-up in ultrasonic and CT studies. This is a close polytrauma of abdominal area. CT angio shows a big rupture, hematoma, and hemorrhage in abdominal area. We also see that the contrast was extravasated beyond aorta, which shows that the hemorrhage is ongoing. The patient was taken to the OR. The sutures were put to close the liver wound and control CT. We see a small hematoma, residual hematoma in retraction area, and this is the contours are sharp and even. The patient is being healed. This is a traumatic pseudoaneurysm of the splenum artery. The CT angio shows you a big chunk of hematoma and pseudoaneurysm. It was decided to do the angio. The CT showed the imaging, and then we confirmed it when we did a classical digital angiography. The decision was made to do embolization of the vessel. The embolization was done, but the clinical course was very, very alarming. On day 4, it was decided to do the CT angio to assess the results of embolization. And we see that in comparison with the previous imaging, the splenum is bigger in size because of the subcapsular hematoma increased in its size. So the decision was made to do laparotomy. During laparotomy, we can visualize here the splenum. It's large in size, and we can see a big subcapsular hematoma because of the inefficiency of laparotomy. It was decided to do splenectomy, and in this case, it's only the CT that helps you to assess the result, predict the complications, and make the right decision on the strategy of treatment. This is a trauma of left kidney, native CT. We can see hemorrhage in this part of liver. We can see that hemorrhage is ongoing. We did the CT, arterial phase on the left and the venous phase on the right. We can see the left kidney is damaged. There's a rupture. And the delayed CT showed us that we have a rupture in the pelvis part. The damages of gallbladder, when we did angio, we didn't see any extravasation. We can see some free liquid, however. In terms of density, we couldn't really identify what this is, whether it's blood or it's urine mixed with blood. It was difficult to say. But since the pelvic bones were fractured in a typical localization, we suspected the trauma of gallbladder. We did CT cystography, and we saw that the contrast showed that urine went beyond the gallbladder, and it was an extra-abdominal rupture of gallbladder. In this way, multispiral CT and angiography is a method of choice during the non-invasive diagnostics of thoracic and abdominal traumas. The application of multispiral CT and angiography helps to identify and describe in details the traumas, assess the failures of vessels and hemorrhages, choose the adequate treatment, assess the efficiency, and assess the complications. Thank you for your attention.
One question. Thank you for your presentation. If no questions, then myself. What do we do with a patient who has an allergy for iodine and we can't introduce the contrast, or the nitrogen metabolism is violated with a possible violation of the discharge function, of the renal discharge function? This question is always present, and it is very painful because the law monitors this very carefully. If the patient is admitted in a severe condition, if we manage, we perform creatinine, and we take into account the glomerular filtration. If it is 60, then it is possible. If less than 60, it is dangerous. If 30 or less, better not to do. But there are life-saving indications. So we carry out these studies, but it is possible that after this we carry out hemodialysis, if at all possible. Besides, we need a consensus, a kind of discussion of various experts, those who are dealing with hemodialysis, surgeons, radiologists. The whole team has to make a joint decision for or against of the test. But I may tell you that in this way we managed to resolve some problems. For example, aortic damage, aortic dissection, whether of traumatic origin or non-traumatic origin. Who, if not us, the radiologists, may perform this study? We know that in classical angio, we see only the lumens. in case of aortic dissection, but one of them may already have a thrombus, and we won't see it. Based on the data, we will see the lumen, which is radio opaque only, but we won't see anything else. So a method of choice is MSCT, nothing else. And everything certainly is in the interest of the patients, but we have to make a decision. We certainly can operate the patient, install the stent graft, but then resolve the situation with the help of hemodialysis, especially in case of aortic dissection and the renal arteries being involved. But then the question, what's to be done with this patient? In case of trauma, yes, we have to carry out these studies, but in order to carry out the blood test for creatinine count, 10, 15, maximum 20 minutes is sufficient. When the patient is admitted and the catheters are installed, we can perform the studies as well, based on the experience of the Institute of Emergency Medical Care. The diagnostics, all the diagnostic procedures are concentrated in the admission unit, and the anti-shock operation room is nearby. So this kind of layout allows to perform all the studies very quickly. We have a portable ultrasound machine that allows us, for example, to detect free blood in the abdominal cavity. If we perform CT, if we manage to perform CT, we perform this with contrast if indicated. But we can't open the gates broadly for introducing the contrast. We have to do what has to be done on the basis of reasonable sufficiency. Sorry, we're very short of time. I know, so thanks, and thank you for your wonderful presentation. The next presentation will be delivered by Sergei Rut. Highly esteemed colleagues, the incidence of violation of main arteries or veins among all mechanical traumas are quite rare, around 3.2%, but the mortality in case of such traumas reaches 90% and higher. The main reason usually is high energy trauma, like a traffic accident, for example, or falling from a height. The priority method is CT, and this is quite recognized today. It allows us to identify all the traumas and also the signs of continuing bleeding. Intravenous introduction of contrast is also used. It allows us to identify all the changes. On the one hand, we allocate a lot of hopes to these studies, but on the other hand, there are data that show that people sometimes overdo these studies, and another study dated 2016 says that only 30% of possible damages may be identified with this study. I mean the CT. And the study was aimed to investigate whether CT is overused to identify such changes. The CT, whole body CT protocol, gives better results and outcomes in patients with trauma compared with CT of selective regions. We do not have such a huge experience of such studies, but we carried out the analysis of our series. When providing medical care to these patients, the organization of the process is crucial. The CT protocols, depending on the equipment, different institutions have, may differ as well, but not significantly. And in literature, we now read about MSCT in case of trauma. Usually brain, then the cervical spine, thoracic and abdominal regions, and pelvic region with abdomen are studied. In addition, angio may be added of brachiocephalic arteries, venous phase in order to confirm extravasation and others. Usually, the damages of these areas may be caused by trauma. And the study of the whole body means a lot of studies, but and in the result of these studies, all these studies mean a lot of work and a lot of labor. And any guideline would tell you that you have to perform all these studies very carefully. And our French colleagues carried out a very broad study from 2008 to 2016. They have analyzed 2,300 studies, and this showed that 530 damages were missed during the first study, and 20% of these damages were of clinical importance to the patient. So when we select the protocol for the diagnostics of these patients, we have to look at the principle of reasonable sufficiency and the diagnostics of the most important patients, important for the patient. Aside for the mechanism of trauma and the indications, we have to take into account the following groups of patients. Severe polytrauma with hemodynamic stability and isolated trauma. Trauma of usually the patients with low traumatic force of trauma and medium traumatic force of trauma, usually these patients will be stable, but we have to cover the brain with CT. Isolated trauma usually demands radiological study. When we carry out CTA, we have to take into account that we very often do not pay attention to the position of hands of the patient and arms, and very often this leads to artifacts that hinder us from reading the scans right. If we know the mechanism of the trauma, we can more or less properly assess the damage or no damage of the upper brachial girdle. What should be said here? Native and contrast CTs will take around 20 to 30 minutes per each. Hence, we can carry them out only if the patients are hemodynamically stable. Around 40 to 45% of this time will be allocated to the delivery of the patient to the CT department, 10 minutes per scanning itself, and then some time that is necessary for radiologists to interpret the scans. Hemodynamically unstable patients, for them, such an approach is unacceptable because we are losing too much valuable time. The main sign of such patients is lack of communication, and the doctors look only at the data about the trauma mechanism. As a rule, such patients, we need to eliminate the life-threatening conditions. That's why the algorithm for such patients doesn't envisage stagnating CT study as one of the options. It may be a simultaneous scanning of the whole body in the position which the patient occupies, and only one contrast study from head to symphysis. Native CT is not necessary because it simply adds time, and only if there is high probability of a very severe damage to the brain, we have to carry out additional studies, additional CTs. For other patients, post-contrast study is carried out immediately. Sometimes with the additional studies whether the patients are allergic to contrast or not. And also taking into account the weight of the patient, 100 ml if the patient weighs up to 75 kilos, and 130 ml if more than 75. Very often the blood pressure will be very low in such patients, so the deferred scanning allows us to diagnose the extravasation of the contrast more often. 10% of cases unfortunately remain undiagnosed, but up to now this is the best of protocol we know. The best of options, if there is such an opportunity, is to have hybrid operational room with the angio CT at the point of medical care provision, because it speeds up medical care. Such systems have been developed already, and in St. Petersburg we have 2 hybrid operational rooms. What such study gives us, what such imaging gives us, the quickest study. Usually this is a sliding gantry that allows us to speed up the study, and the flexible table. So all of these systems are really justified to be used in practice. These are our clinical cases. Aortic damage in a very typical location in the region of isthmus, and it was a patient with a very severe trauma after the traffic accident. Another case, and also traffic accident, and we see a lot of blood in both pleural cavities and acute dissection of the aortic wall, which very often demands additional study. To make clear the nature and length. Another case, dissection of the aortic wall, that is visualized very well. Cervical spine here, and the fracture of the first vertebra with the damage to the vertebral artery. Catatrauma, thoracic region, subclavicular artery damage, extravasations, signs of the contrast. Also very well seen. Another case, and another patient was wounded with an arrow. It was an attempt of suicide. The time ran out. You've seen on the slide 2 arrows actually. It was not 1 arrow but 2 arrows, and they damaged thoracic aorta into locations. He was very quickly delivered to a specialized center where this CT angio was carried out. Thank you. And thank you for your presentation.
The next speaker. The next speaker is Dr. Junichi Matsumoto. It's great honor to me to introduce my mentor in radiology. He's a radiologist, but he's working in the trauma and emergency patient exclusively. He's going to present the Presto concept for trauma and image strategy. Please start.
Thank you very much for having me here. I'm so honored. Today I'd like to talk about my concept called Presto. And in the setting of the patient is hemodynamically very, very unstable, in that situation surgical approach is preferable. And there is no little chance for imaging and endovascular procedures. Otherwise, even the patient is a little bit hemodynamically unstable, I think diagnostic imaging, especially CT and endovascular procedures, are very useful. And to me, those look essential in trauma care. But it is important for them, those should be applied appropriately. As you know, major guidelines do not recommend CT and IR endovascular procedures for hemodynamically unstable patients, maybe because poor on-time availability of radiologists, can be lack of passion of radiologists against trauma, or can be their time consuming. And I think one of the major reasons is lack of understanding of time-conscious radiology. That's why we have suggested PRESTO concept in 2015. PRESTO is an abbreviation of prompt and rapid endovascular stretches in trauma occasion, consisting of 4 factors. The first is early activation of endovascular team as well as diagnostic radiology team. Here you can see waiting for the patient together with the clinical team, and I'm trying to get the arterial access and the femoral artery. And it is also very important to assign someone for imaging evaluation only. We call these strategies IMINT, Imagery Intelligence strategies, because imaging information is very, very important in trauma care because it will tell you presence or absence of injury, number of injuries, severity of injuries, and how to approach to them. So you can decide with those imaging information. So that's why I emphasize that you need to put someone to evaluate images. And you may say, no, we have radiologists, but the important thing is not put someone in the reading room. You have to put someone in the team by the patient. It is important. That is IMINT strategies for us. And it is also important to combine information about mechanism of injury and time from the event when you evaluate images. And yes, here you can see me waiting for the patient next to the monitor. And we have monitors near the head of the patient. And we share the images within the team during the primary survey or secondary survey. And when we get a patient, my job is to evaluate images immediately or almost at the same time when the images are obtained. And we say this chest X-ray obtained.
И дальше мы делаем, посмотрите, пожалуйста, вот эту визуализацию мы получили через 40 минут после травмы. Я не вижу пневмоторакса, но слева я вижу травму, и она может навести меня на мысль о разрыве селезенки. То есть такую вот информацию я могу дать при первичном осмотре и при рентгенограмме. Также очень важно иметь протокол ультрабыстрого сканирования и быстрой оценки КТ-изображений. Это видео с...
CT room stay time. Could you play the movie, please? Oh, okay. No, this is not the right one. 2 slides before, please. Go back. No, one more. Yes, and please start. Put the mouse on the image. Okay. And this is the movie from the training, and we use 80-kilogram phantom doll. And could you forward to the first arrow? We set the patient on the scanner. Could you move to the forward, to the first slide, first arrow? Could you move to the first? No, to the first arrow as we practiced. Okay. In that movie, what we tried to do is to reduce CT room stay time. From the time to entry, we can we don't do the movie. It's okay. We don't do the movie. And we try to reduce the CT room stay time. And from the time from the entry to enter the CT room and put the patient on the scanner and scan the patient, non-contrast head CT with giving contrast and finish the head CT before the contrast coming up to the head, and do arterial phase and delayed phase. And we can finish the whole process like 3 minutes and 30 seconds. So in that situation, I think you can scan more hemodynamically unstable patient. So it is important to have different CT protocol for according to the hemodynamics. So I skipped the movie again, and even in the actual case, this is not a training case, even in this case, even when we have a scanning protocol, even in that setting, we could finish the whole process from entry the CT room to getting out of the CT room. We could finish within 5 minutes. So if we train the whole team in collaboration with the other specialties, you can finish the CT room stay time shorter. So, but it is very important to train the whole team and to share the concept. Then you can do that. And it is very important to have adequate method in evaluating trauma pan scan images, because the images are so many. So that's why we have suggested focused assessment method. It is called focused assessment with CT for trauma. In that, all we have to do is evaluate surgical intracranial hematoma like this, and skip the neck, go down to the aortic arch to evaluate aortic injury, and go down to the lung-based with evaluating bad lung injuries and hemopneumothorax, and after that go down to the below the diaphragm, we go down to the pelvic floor, because most critical pathology in the abdomen is large amount of hemperitoneum. So that's why we go down to the Douglas pelvic floor to look at the Douglas's pouch, because significant amount of hemperitoneum goes down to the most gravity-dependent part of the pelvic floor. So that's why we go down. Then retrogradally, we go up to evaluate pelvic fracture and retroperitoneal hematoma, which is not evaluated in the primary survey. And after that, we finally evaluate solid organ injuries and the mesenteric hematoma. Important thing is you have to finish the whole evaluating process in 3 minutes and not to stop even when you're in doubt. So if you can do that, you can you can make a rough decision during examination. And it is also important to think of injury mechanism during evaluation, and CT information is also useful in making this kind of virtual angiographic image. Then all you have to do during angiography is not look for the artery, you can aim the branch. So CT information is very useful. And it is, again, also very important to put someone keep on reading images during a CT scan and right after CT examination in the ER. And the yellow dotted circle is indicating me reading behind the screen. And I show them the images to them, but no one look at the images. So in that situation, I say extravasation from the spleen and pelvis, hepatic injury without extravasation kind of thing, I say loud. Then we can share what is going on. So it is also very important direct transfer from CT according to the results of focused assessment. And then in this case, we could start surgical brain surgery and abdominal angio at the same time in the ER right after CT. And in the surgical case, again, the imaging analyst should follow the patient and go to the OR and keep on reading and giving more information to surgeons to make surgery better. And also important to apply damage control concept to endovascular procedures. In that, you have to, the primary concern is saving life, and you have to finish, for example, this is the case with pelvic fracture and splenic injury. In this case, you have to embolize one splenic artery and bilateral internal iliac arteries. So you need to embolize 1, 2, 3 arteries. So you have to finish whole process in 30 minutes. So this is the PLAST concept, and if you can apply this concept, you can save more hemodynamically unstable patients with radiology. Thank you very much for your attention.
Спасибо за прекрасный доклад.
Thank you so much for your brilliant presentation. Any questions to the speaker? Any opinions of experts?
For speech. In my countries, I know the concept, the radiologist always accompany the trauma case is very important. But in my country, it's very difficult because our radiologists, they were not on duty at the hospital because we need to pay. I don't know how about in Japan.
The next slide didn't show up. It shows that in our country, Japan, 24/7 radiology coverage is very, very rare in Japan. So that's why we need to train emergency physicians and trauma surgeons to read images and to do endovascular procedures. So that's why we created a society named Direct Society to train them, to share the knowledge and skills.
Спасибо. Вопрос.
Скажите, пожалуйста, секунду, один вопрос.
Just a second, there's one more question. Please tell me how many CT images you do per day, per 24 hours, and CT angios as well. How many CT angios and CTs are you doing per day?
We have maybe 20 for 24 hours or more, about I think 30 for 24 hours. But we also do brain chest radiographers. We also read. So we have many imaging studies. So that's why we have radiologists in the emergency center. But in the other hospital, much, much less number of studies. So it is not easy to have radiologists.
Спасибо, но маленькая ремарка.
Thank you. Here is a little comment. In the emergency hospital, the average CTs per day, 100, 120. Thank you. Thank you for your great presentation indeed. And we'll listen to another opinion on Presto protocol. Speaker Anatoly Zavrazhinov, he will give our outlook at this protocol. Good afternoon again. And the organizers challenged me because in this or that way, I am dealing with the Presto strategy for 30 years now, fully or partially. What do we know about Presto? Translated from Italian, Presto is a tempo in music, and it means quickly. As different from Allegro, Presto sounds really quick, really fast, and I would say aggressive a bit. And the difficulty often requires the musicians to really master their skills in a virtuous manner. And this is really typical for the doctors too. Look at Presto. Look at how vivacious this lady is performing Vivaldi's music and how she is smiling. Well, nevertheless, let's go back and say that thanks to Professor Matsumoto, we know that Presto is a strategy for the prompt and rapid endovascular strategies in trauma occasions, and the main motto is start earlier and finish sooner. How do we understand Presto strategy in Russia? Well, thanks to the fact that in Rebro we listened to Professor Matsumoto for the first time and we wrote his We read his article in 2017, and we reported on Presto method in Moscow in 2017. And thanks to all this, we introduced a timely transition from PCI technologies to the alternative open methods of stopping the hemorrhages. To reduce the treatment time is possible not only due to endovascular approaches, but also due to the timely deployment of traditional surgical methods. We learned that in order to implement Presto concept, we need a hybrid OR. A hybrid OR combines not only open surgery method techniques, but also angiographer and a coil tomographer. The hybrid OR can be in 2 rooms or in 1 room, but we should have a hybrid room, a C-arch with angio add-on in a regular OR where we do PCI interventions is also a choice. We need the devices. I will not go deep in it, but without the devices and the materials, we can't implement the Presto concept. In the OR, we need a mobile ultrasonic device for fast study, a device for intubation, video laryngoscope, and a toolkit for hemorrhages, as well as intensive care unit and we need to have the tooling and devices to warm up the patient, and we need to have a hemotransfusion device as well. But the most important thing to implement this concept is organization, organizational solutions that emerged in Europe in 60s and 70s of the last century. 5 main components are the timely care on the site of accident, pre-hospital care, timely delivery of the patient to the hospital, early intervention and rehabilitation. This led to division of the clinical institutions into trauma centers. Unfortunately, in Russia, we started this development since 2005 only. At the moment, we have a network of trauma centers in our country. We have the intensive care vehicles and the golden hour standard. We have helicopter emergency evacuation of the patients within the so-called platinum 10 minutes. Nevertheless, you can't just do the emergency delivery of the patient and have no Presto in the emergency department, where not only you should organize the emergency care and the logistics of the patient circulation, but also it should be done in 1 room, on 1 floor, in 1 premises. And the key element of it is a shock OR and a multifunctional team working 24 hours a day and able to conduct the relevant events according to the guidelines is it's a must. And if a team is working like this, and I'm sorry for the cartoon, but it reminds of the funny thing illustrated here. So what are the main hurdles for Presto concept in Russia? Let me say that I'm sorry to mention this, but we have a lack of funding and absence of a holistic approach. The approximate cost of a hybrid OR with all the devices and machines in place is around $5 million. 350 million rubles is what we need to equip the hybrid OR. Yes, in Russia we have vascular programs. We have the emergency care for the victims of accidents. But what we do is we have vascular centers in 1 place and trauma center in another place. And very often the trauma center doesn't have the full scope of knowledge and skills and hands to implement this approach. Unfortunately, many general surgeons and trauma specialists have no basic knowledge on PCI methods of treatment, and they are focused on traditional surgery. Although we know great examples of Victor Reva and other surgeons who really implement this approach and do the endovascular surgery in case of traumas. What are the other obstacles to implement Presto in Russia? Well, the second thing I wanted to mention is the following. The endovascular surgeons are simply unaware or not interested in the treatment of severe traumas. They don't know the damage control tactics and the basics of it, and they don't know that sometimes it's time to stop doing an endovascular surgery and start open surgery, because endovascular damage control is not the same in eliminating the consequences of ischemic stroke or acute coronary syndrome. In emergency medicine, it's a totally different thing. What else is not letting Presto develop in Russia? A low level of interaction between different departments and specialists of the same hospital. Look at the well-aligned teamwork of the emergency unit, how well our helicopter services are working, how well the CT scanning is happening and the surgery is happening at a time. Look at all this. Nevertheless, there's still a very low level of understanding. Can we hope that these difficulties will be overcome? I want to take the opportunity and say that we are really proud of a new center built in the Military Medical Academy, and in the next presentation we'll hear more about it. And we have a very well compiled hybrid OR. It has all the CTs, angio, and other machines in place. We have blood transfusion machine and all the other conditions in place for open surgery there. Yes, indeed, due to the efforts of Igor Samakhvalov and his chair, we introduced a smart educational course where surgeons and trauma specialists are taught the basic skills of endovascular interventions. And of course, look at this slide. You can see here the allocation of trauma team specialists. It's marked on the floor and everybody knows their place, and the PCI surgeon is part of the team. Look at this red arrow.
When a severe patient is admitted and the strategy of emergent medical care is developed, only with this approach we can achieve good results. Thank you. Thank you for your presentation. And we have questions. Thanks a lot for your interesting presentation. My question is as following. You mentioned $5 million US. What do you think? How often are you going to use this hybrid operation room for the patients? How many times a year? Your vision. How many patients a year can you cover with this OR? Thank you for your question. I do not like to start the answer with this phrase, but I've underlined several times that this is not just treating severe patients. This is emergency work, emergency OR, where the whole flow of severe, wounded, traumatized patients will be delivered. These patients may have cryogenic shock on the background of MI, coma on the background of ischemic stroke, gastroduodenal bleedings, uterine bleedings. But how many patients a year? You have such a powerful institution. At least once a day, are you going to use this hybrid OR? If we take the experience of the emergency institution work and the Sochi clinic, where there are many traumatized people, it will be from 50 to 70 people a year. No, a day. And all of them will be delivered to this hybrid OR. This is Presto concept. Thank you. Thank you, Anatoly. Any questions more? Thank you, Anatoly, for your presentation. Thanks.
Takahiro Kinoshita. I'm very lucky to introduce my friend here. he's trying to spread the benefit of hybrid ER, not hybrid OR. So his topic is hybrid shock room, a new era for trauma surgery. So please start your presentation.
So thank you, Yosuke, for the interaction, and thank you, Victor, for having me. It is a great, great honor for me to make a presentation in this cutting-edge conference. And I have received a lecture honorarium from Canon Medical System in other conferences, and I belong to Japanese Association for the Hybrid Emergency Room System Scientific Promotion Committee. So these are my COIs. And today, I want to talk about the novel trauma management system created in Japan. And let me start with the background. So 20 years ago, computed tomography was considered as a time-consuming procedure. So it was considered to be used only in hemodynamically stable patients. It is also called tunnel death because many severe trauma patients died on the CT table. But the emergence of MDCT dramatically reduced the time to take CT scanning, so now we can obtain high-quality images within short amount of time, so the situation has been changed. And recently, 2 important studies were published from The Lancet, but effect of whole-body CT scanning during trauma resuscitation is still under debate. And another innovation in this field is, of course, endovascular treatment, but recent guidelines in the US recommend that non-operative management based on angioembolization of, for example, blunt hepatic injury is the treatment modality of choice, but it is limited to hemodynamically stable patients, and for hemodynamically unstable patients, emergency direct surgery is still considered a necessary procedure. So in summary, we can say, although CT scanning in interventional radiology or angioembolization is effective in trauma, but it is not recommended for unstable patients yet. Why? It is partly because we have a fear for a treatment delay, because if we wanted to use these kinds of equipment, we have to transfer patient from emergency room to the CT room or angio room. So we thought that eliminating transfer time is required. And in 2011, we installed an angio CT in the trauma resuscitation room. So it consists of sliding gantry CT scanner and self-propelled shear. But we also have ventilator, vital signs monitor, and ultrasonography. So now we can perform CT and surgery and IR even on the same table without any patient transfer. So the concept is based on the combination of examinations and treatment in a single place. We named this room the hybrid ER. So let me show you a video of trauma patient using the hybrid ER. The first case is pelvic ring fracture. So in this case, we could start CT scanning within 5 minutes from arrival, and we found multiple rib fractures and open book type severe unstable pelvic ring fracture with massive retroperitoneal hematoma. So in this case, we performed both internal artery embolization and saved the patient. Next, I want to discuss the effectiveness of this system using our data. 2 years ago, we have published the first original article in Annals of Surgery. It was a single-center historical control study, included severe brain trauma patients. And in the conventional group, there were 360 patients, and in the hybrid ER group, there were 336 patients. And first of all, the time to take CT scanning was reduced from 26 minutes to 11 minutes. And time to start operation, surgery, or endovascular treatment was decreased from 68 minutes to 47 minutes. As a result, the 28-day mortality was decreased from 22% to 15%, and especially, deaths from exsanguination became less than half. And in the 3 models of logistic regression analysis, the hybrid ER group was significantly associated with the improved mortality. So we have demonstrated first that this system is super effective for a hemorrhage patient, but in this article, we found no significant difference in the patient with deaths from TBI. So next, we focused on the functional outcome in patients with severe TBI. So it was post-hoc analysis of the previous study, included severe TBI only, and we compared the outcome of conventional group and the hybrid ER group. So this is the result. As you see, the deaths and, deaths is here and vegetative state were decreased, but instead, severe disability and moderate disability and good recovery were increased. And after adjustment of baseline severity, the hybrid ER group was significantly associated with improved functional outcome. So in summary, our system may shorten time to take CT scanning and realize RE intervention, reduce exsanguination, and improve functional outcome in patients with TBI, and decrease 28-day mortality. So we have succeeded in improving outcome of trauma patients, but we believe we need further progress to use this system effectively. So I want to show another case of multiple trauma patient who are treated in the hybrid ER. So CT showed that right acute subdural hematoma and multiple facial bone fractures, bilateral pneumothorax, hepatic injury, and severe pelvic ring fractures. So in the second CT, we found that right acute subdural was removed well, but retroperitoneal hematoma was increased. And the patient was still in shock status, so we added the preperitoneal pelvic packing and external fixation. After 3.5 hours of initial stabilization, patient discharged to the ICU. So ISS was 57, and probability of survival was only 3.3%, but the patient returned to her social life. So next, I want to discuss that we could now, we have reported that the concurrent breathing control surgery and neurosurgery is feasible in the hybrid ear. So this study is single-center retrospective observational study for 7 years. Oh. Really? All right.
Could you wrap up your talk? Wrap up your talk because of the time.
I think I didn't spend 15 minutes. Thank you. But anyway, we reported the outcomes of 10 patients who received concurrent breathing control and neurosurgery. And this is a result. Among 10 patients, 4 patients have survival to discharge, and 2 of them had favorable neurological outcomes. That's it. This is the only result in this paper. 4 survived and 2 returned to the social life. But I believe this is the significant progress in the field of trauma. As you know, in the conventional trauma management system, you cannot take CT scanning in a hemodynamically unstable patient. So this means that you cannot treat or even evaluate intracranial hemorrhage in patients with hemodynamic instability. So, and we demonstrated that if you use this system, the hybrid ear, we can perform concurrent bleeding control and neurosurgery. So this is the final slide. Benjamin Franklin said, "Time is money." Instead, I want to say, time is life. Спасибо, thank you for your attention.
Thank you for your brilliant presentation, Takira. Any questions?
I work in Helsinki in a setting where we have 2 hybrid ORs working all the time, 24/7, and we do vascular procedures there. So we do not focus so much yet on trauma. We are planning a new hospital to combine the trauma, neurosurgery, and vascular surgery together, and are buying now a new Rapture and getting 4 more hybrid suites. So we have the setting. I was impressed by your videos and everything, but I have to be a bit critical because you are doing a lot of compromises, both in sterility and in radial protection. We actually started now a radial protection study, but in our vascular cases, in our hybrid OR, but the problem is that we get about 0 radiation, and we use much more radial protection that you do there. And now I'm in the phase of planning how to organize the trauma and endovascular procedures, both in the Rapture and in the new hybrid suites, and I'm struggling with which patients we should take where, because we have 2 CTs in the emergency room. We can run them quite fastly, and then we can take the patient out. So that patient would not occupy the CT anymore for the upcoming stroke patient or whichever for emergency CTs. So what do you think in your setting, in that room, for example, I would not do tape-high dissections or EVARs that easily. It seems a bit crowded when you need a lot of new machines like perfusion machines and cardiopulmonary bypass machines. So how do you divide your patients between this and maybe a more formal, larger hybrid suites?
So thank you for the important question. And first of all, we do not perform surgery routinely in the hybrid ear. So of course, because we have a problem in sterilization, so we sometimes send patient to the OR, but in the hemodynamically unstable patient, we perform damage control surgery in the hybrid ear. And next, we always wear radiation protection gown before patient arrival. But we do not routinely go into the hybrid ear during CT scanning, but it is only for the most severe trauma patient requiring pumping of transfusion during CT scanning. And the last question is very important, and unfortunately, emergency medicine in Japan is very different from the other countries, so it is difficult to compare, but we recommend you to limit this room, the usage of this room to the physiological, to the trauma patient with physiological abnormality. So disturbance of consciousness or low blood pressure or tachycardia. And I can say that we have 1,300 admission to the ICU last year, and almost all patients received initial stabilization in the hybrid ear. Not all of them are trauma patients, but almost all of them received treatment in the hybrid ear. And we have experienced like duplicate of transfer like less than once a month. So it doesn't happen so much. But in that situation, you have to choose the most potentially severe trauma patients. Thank you.
Следующий вопрос.
Next question, please. Well, I'm an intensive care unit doctor. I'm from intensive care unit, emergency hospital. I want to clarify, did I understand correctly, the first case that you showed in your presentation, if I understood correctly, the patient who you didn't detect saturation and oxygenation, and the start of the patient on the heart-lung machine was 5 minutes after CT scan was done, right? Was I right to understand? And my question is, why did you do so? Why did the intensive care doctor start working with the respiratory system of the patient after CT scan in 5 minutes? Because even before CT, you could take the patient to the heart-lung machine. Or maybe I didn't understand it in the right way and your focus was on the surgical tactics and it was a defect of imaging. So please explain. So in the first movie, I didn't show the vital signs monitor. But we, of course, measure vital signs immediately after arrival, and within 5 minutes, we routinely take IV access and perform start vital sign monitoring before CT scanning. That's all. But in in patient with respiratory instability, we sometimes perform intubation before CT scanning, and in that situation, we take a line or insert a urinary catheter before CT scanning, and we try not to delay the definitive surgery. So, but anyway, so we have, of course, CT scanning itself is still dangerous in our system because we cannot perform any treatment for the patient during scanning. So we need a vital signs monitor during CT examinations. Am I correcting right? Does it make sense?
Let me add some comment. In my understanding, probably if the patient has the airway problem or if the patient is impending cardiac arrest, the physician needs to resuscitate before the CT scan. But if the patient has the circulatory problem or a respiratory problem, in this ER, a hybrid ER situation, they allow the CT scan prior to the intubation. But it depends on the situation, but we need to allow this kind of dangerous CT scan in this ideal hybrid ER situation.
Yeah, so Yosuke supported like us. So there is a kind of airway breathing CT in our concept, but not always, of course. So sometimes we perform revo or resuscitative thoracotomy before CT scanning, but we check airway and breathing and go to CT. That's it.
Спасибо.
Я вас понял.
Скажите, пожалуйста,
I got you. Thank you very much. Any other people, any other doctors to ask questions? Maybe our panelists want to ask questions, make some conclusions. Okay, then let me ask you a brief question. Please tell me how many hybrid ORs, hybrid emergency rooms, are in the trauma centers of the first level in Japan? Or are you all equipped in a similar way in Japan, in all centers?
So now we have 11 trauma centers in Japan which that have hybrid emergency room. And in almost all trauma centers, we use it as in our hospital.
спасибо. Thank you.
Thank you.
Thank you. We would like to continue. And the next three presentations are on vascular trauma. And the first speaker is Pavel Ivanov, orthopedic surgeon's view on vascular trauma. Good afternoon, dear colleagues. First of all, let me express my gratitude to the organizers for this kind of a unique conference, and thank you for the privilege to talk about the combined traumas of bone fractures and large vessel damages. As for the large studies that would study the incidence of these kind of polytraumas, there are lots of them, and almost half of the traumas are caused by stabbing, or they are the gunshot traumas, the closed traumas, especially in the perspective of amputation of limbs, is the worst, because the closed wounds are causing large-scale failures of soft tissue and bones, and they are all usually representing a polytrauma. Isolated damages of vessels without fractures is hazardous for further amputation of limbs, but it's even worse to have a combined trauma of a vessel and a fracture, and this is the case we are dealing with in overwhelming majority of situations. The most frequent combinations of traumas of bones and arteries in closed fracture cases, closed type traumas. In case of closed type traumas, in terms of incidence and hazard for further development of hemodynamically dangerous situations, are the pelvic wounds with fractures and hemorrhages, or the displacements of the large tibial bones. The early and late consequences of these large artery traumas among patients are hazardous. Very often we face blood loss, especially in polytraumas. With the developing ischemia of lower limbs, it's important not only locally, but also it may develop endotoxicosis in the patient, and hypoxia, compartment syndrome, necrosis of tissues, and early amputation. If we're talking about long-term results of treatment and late complications, we very often face purulent processes, the slow healing of fractures or false joint formation, osteoporosis locally. The functional outcomes are not so good for them, and the patients very often are diagnosed chronic osteomyelitis. The attitude of traumatologists to the damages of the main vessels and arteries is very, very cautious, and very often we are alarmed by them, and thus very often the main lesion damages The Gasillo-Anderson classification of open fractures is the most typical one. Type 1 is wound with the fractures and main lesion failures. If we're talking about the scale to assess the severity, here is the score. And in every, here are all the scores, and every score has an important parameter such as the ischemia of the limb. The risk factors for the amputation in case of severe bone fractures. Please look, 3 factors are dealing with the damages of lesions, open fracture, Costello type 3, and popliteal ischemic artery failures. The fractures, of course, are diagnosed by in clinical environment, but please keep in mind very often fracture is masking the failure of a lesion, or sometimes it may lead to a hyperdiagnostics. The tool, the machine diagnostics is deployed always. We use ultrasonic Doppler study, CT angio, and X-ray angio. However, in patients with polytrauma, time is of a key concern. Also, it's very important to follow up these patients in the future. Here is an example of our female patient. After a car accident, the patient was the driver in the frontal part of abdomen. You can see the trace from her safety seat belt. And on day 3, here we had a dissection of intima and iliac artery rupture. It led to the decompensation of lower limb ischemia, and then we did the stenting on her iliac artery, and luckily it was the outcome was fine. The treatment is quite complicated. Who is of priority? Cardiac surgeon, vascular surgeon, or a trauma surgeon? What is the time for prosthesis? Preservation of lower limbs and upper limbs. The traditional scheme of treatment is like this. First of all, the vascular surgeons are doing the temporary prosthesis of the vessel, then the fracture is fixed, and then the vascular surgeons are finishing the procedure. This is the way the patient looks with the after fixation, because no plaster or a bus can give a good stability. Here are a few works on the temporary prosthesis of the vessel. Although we can, by temporary prosthesis, reduce the incidence of compartment syndrome, they recommend to do no temporary prosthesis, but to reconstruct the vessel immediately without putting the patient on stabilization. And fractures of pelvic bones, they were talked about today, and very often they are associated with the large vessel ruptures. In 70% of cases, we are talking about the main lesions of arteries. It's iliac arteries or popliteal arteries. The traumatologists are using the early fixation. Very often we're talking about gluteal artery and iliac artery damages here. Aortic occlusal resuscitative endovascular balloon occlusion technique is very efficient, and it should become a practice in our country too. To conclude, I want to say that the main lesion failures in case of polytrauma worsen the forecast of treatment. We need to work in a well-aligned team of specialists. We need to have in place a combination of different strategies of treatment by trauma specialists and vascular surgeons, and the hybrid we're talking about should be there. REBOA is a promising and reliable method of treatment for the pelvic injuries and concomitant hemorrhages. Thank you for your attention. Next presentation by Vladimir Soroka. After 3 presentations, we'll have a brief discussion and a Q&A session. Dear colleagues, I was thinking of how we write in Russian, not very young together or separately. Should I write old or young? So I wrote the view of a not very young surgeon. Many of us are not familiar with the fact, but there was this person, Dr. Janelidze. He was the first doctor in the world to do the suturing of the ascending aorta wound. And I was ashamed to know about this from one of the best books on trauma by Maddox Feliciano. And I think many of you have read this book on trauma, although Janelidze here his name in English is written in a very strange way. We can't really identify it, and the year was confused. It's written 1922 instead of 1913. Look, on one hand we see Visalio, on the other hand we see Michael Debicki, Denton Cooley. In fact, vascular traumatology began after World War II, when the Americans conscripted to the army the young, well-educated vascular surgeons, and this enabled them to reduce the number of amputations 3 times. A lot has been said about education today and training, and I will try to continue this topic. And of course, I would like to mention another military surgeon, Vladimir Opel, who highlighted the importance of evacuation and logistics. Education is the key factor for a survival. Today we were talking about golden and platinum minutes. I really believe it's very important, and very often the self-assistance and help of a peer in case of hemorrhages plus education of the doctor are of key importance. If we're talking about vascular traumas, we have around 40% of patients with vascular traumas. We can say the same about St. Petersburg, for example. You can see that the vascular trauma is not growing much. This is the consolidated statistics of 16 departments from different centers in St. Petersburg. St. Petersburg has 5 million population. You know, I liked very much the presentation from our Brazilian colleague. Of course, Neva is not Amazon River, but we have similarities indeed. The number of surgeries, vascular surgeries, and arterial reconstructions is growing, and it's growing due to mainly arterial input. There was a great presentation by academician Alekian. You know, this Caesar-shaped graph did take place globally, but not in our country. I mean, open surgery and its proportions to the PCI. Well, trauma is number 3 most frequent cause of death in Russia. Out of 2 million deaths per year, 200,000 die as a consequence of trauma in Russia.
If we calculate roughly, if we take 0.5% without military traumas, Pavel Georgievich, who is present here, is one of the classics of the military field, battlefield traumas. We will have around 5,000 to 6,000 vascular damage in Russia. Based on the reports, 1,000 was treated only by vascular surgeons. How many are treated out of these 5,000 are treated by endovascular? Very, very few. We mentioned education. Shall we educate vascular surgeons up to the level of endovascular surgeons? Low probability. Even less is that general surgeons will reach the endovascular professional surgeons level. I can compare here endovascular surgeons with those who love opera. You are now in one of the best cities of the world in St. Petersburg. And we have wonderful theaters here, including Mariinsky, and I recommend you to go there. I'm not going to launch Verdi or Tchaikovsky now, but I would say that we have to be professional both on the side of the popular music and moreover on the side of the classical opera. Everybody demonstrated their cases. I have some one something minute left, and I will show you some clinical cases of happy people who lived happily and died the same day. This is a well-known couple. When they had an anniversary, they decided to go on a trip, and only 12 minutes passed after he arrived to Sarajevo, but a bomb was thrown in his direction. He had some commotion with the mayor of the city, but continued his trip. And as usual in history, everything depends on some small details. He after that decided to visit his friend who was wounded during this explosion. And one of the terrorists was sitting in a cafe, drinking coffee, and the horseman didn't know the way, so he stopped in order to find the way, and the terrorist shot 2 times and wounded both the Grand Duke and Grand Duchess. It was a deadly wound. The Grand Duke asked to bring him back to his residence, not to the hospital. Did he die from blood loss? No, I think he died from air embolism, and most probably from the fact that the primary medical care was not provided. So the decisive role was played by people who surrounded him. His wife had an aortic wound, while Franz Ferdinandus died of a different wound, and it gave rise to the First World War, and 4 empires collapsed in the result of that war. Thank you. And now the next presentation, endovascular surgeon's view. Mikhail Maslenikov, the floor is yours. Dear colleagues, my presentation is from the endovascular point of view. You've heard the vascular surgeons and the traumatologists. I will present our series of the EMS hospital of the city of Moscow. We have a lot of patients with traumas who are admitted to our hospital from all over the city of Moscow. And the vascular point of view, we're happy that you see us as people who love opera, but we are working within a team, in our multidisciplinary team, and we try to evaluate the patient at admission. Several principles. Our department was organized in 2014. We admit patients 24 hours, 7 days a week with traumas, bleedings, or some arterial injuries. We deal with the severe patients with traumas. No strokes, no infarctions. Unfortunately, the opportunities of hybrid ORs are not about us. I'm sorry for this delay, but the organization of the work is as follows. At pre-hospital stage, we try to evaluate the patient. If the patient is being delivered to our hospital, we want their admission department traumatologist, surgeon, and endovascular surgeon are already are warned, and they gather together, and we can perform CT at admittance. If we see extravasation based on CT and the patient is stable, then initially we start endovascularly. If there are some signs of unstable hemodynamics, then it will be open surgery. In our work, we are guided by the European guidelines as of 2016. If we are not doing rebore, the first class B of the guidelines are and our class of patients are stable patients. Initially, when we started our work and were structuring our teams, and we had patients in angio OR, we were asked that at your angio, we do not see extravasation or bleeding, but there are many signs of endovascular bleedings that do not look as they should or as they are shown in the textbooks. Thank you. We now have the presentation. These are the European guidelines. Our group of patients are certainly stable patients. Based on the US guidelines, endovascular procedures belong to conservative type of care. There are many signs, as I've mentioned. Extravasation is one of those signs. It may be fistulas, pseudoaneurysms, compression of vessels. For an experienced person who are working at our X-ray OR or radiological OR, this is not difficult to find out these signs. The access doesn't matter. The main thing is the access should be performed quickly. Which materials for embolization? By the way, in terms of access, we usually use femoral access, contralateral to the trauma side. And non-selective embolization is also possible. We pay attention to such organs as liver, spleen, because they are suitable for embolization. If there is collateral blood supply, we have to perform embolization more distally. If the main vessels are damaged, to maintain patency, we have to implant stent graft. Several clinical cases, as an example of our work, when vascular surgeons and traumatologists insisted on the initial endovascular procedure. A female, 27 years old, was admitted with the closed abdominal trauma. She fell from height. What hindered our intervention? We could not connect the computer, so I won't be able to show you the video. But this patient had mitral valve replacement and was taking anticoagulants without the possibility to introduce agonists of these anticoagulants. Hence, we considered endovascular treatment. She had a congenital anomaly, atresia of hypogastric trunk. So we use gastroduodenal artery. We see hypogastric. We see pseudoaneurysm of the right hepatic artery with massive intestinal bleeding. We performed selective embolization quite quickly. The aneurysm cavity was glued. We discharged the patient in a stable state, and she didn't need any further interventions. This is a control angio. As you see, all the main vessels are patent, and only the cavity of the aneurysm is closed. Another patient, 25 years old, without CT, he was delivered to angio. The patient had a motorcycle accident. Around 2 millimeters of the diameter of iliac arteries based on CT. When we carried out the angio, we have detected the source that was the mesenteric artery branch. Superselective embolization was carried out, and the patient was discharged without any ischemic violations. One of our recent patients, female, 29 years, stabbing wound of the neck. The wound was quite high, so it was unavailable for open surgery. We managed to eliminate it very quickly and efficiently endovascularly by implanting a stent graft. It was a very severe trauma. After 1 month, she was discharged, but since it was a severe case, she spent almost 1 month in resuscitation. Main success predictors. First and foremost, stable patients, young patients, conscious patients. If it is abdominal trauma, the intestines have to be intact. The motility of the intestines has to be intact. When such patients are admitted to the hospital, they have to be met by a team. We have to minimize the delivery time to the center and provide medical care as soon as possible. Endovascular management can't be an alternative to open surgery and surgery know-how. And once again, this is a teamwork together with the vascular surgeons and traumatologists. If we manage to organize such a team, it is great, because most often it is very difficult to bring together the enthusiasts who will be interested in this work, because this is really the success factor. If you have an opportunity to organize hybrid OR, then in severe traumas you will have 90% of success and higher if you use REBOA. The complications are not that much, and they can be eliminated by surgery later on. What are the advantages in case of selective embolization? Less costs, lower costs, fewer days in hospital, possibility to avoid resection of the organ, and decrease the volume of hemotransfusion. Thank you very much for your attention. And thank you. Now questions. Thank you for your interesting presentation. Tell me, please, your slides did not show. We see classical angio, but no preliminary ultrasound, Doppler, CT. Do you start with angio and surrounding organs and tissues? Or you simply didn't manage to show us everything? Ultrasound is carried out in radiological OR. The possibility to puncture the vessel, the evaluation of the abdominal cavity, fast study. We can carry this out in TROP. If we can carry out CT, we initially perform this for such patients always. I've demonstrated a very severe case when we didn't have an opportunity. By the way, the patient with the stabbing wound into the neck, we didn't have an opportunity to perform CT. No, we performed CT for her, but we do not have such an opportunity for all the patients. Our hospital is very old, similar to EMS Janelidze Institution, and CT is located in a different building. This proves that our specialists may find a way out in any conditions. Thank you. Do we have an opportunity to ask questions? We have an opportunity to ask questions to all the three presenters. Do you think that traumatologists are dealing with traumas while vascular surgeons can operate together with a traumatologist on the main vessels, or not? do you expand the responsibility of the traumatologist? In our institution, vascular surgeon is always at our side. We have 24 hours vascular surgeons on duty, so we have an opportunity to bring in high professionals, and we do this from the very start. As for endovascular techniques, maybe beyond your question, I think that the traumatologist must have some basic skills, for example, to place a balloon or other basic things. Thank you. May I ask a question to you, Vladimir? Taking into account that you represent one of the leading institutions that provide care in traumas and bleedings, hemorrhages, what percentage of vascular surgeons can provide endovascular care, and how many of endovascular, if for example a vascular surgeon is busy, will be able to perform open surgery?
Well, of course, it's a matter of organization. Our institute, Emergency Institute, has 24-hour doctors on duty on vascular surgery. And we have endovascular surgery, stentings, thousands of stentings in case of acute coronary syndrome, for example. And of course, we have 2 teams of vascular surgeons on duty. One team is on duty in the city. We are coordinating the south of St. Petersburg, and the other team on duty is in charge of St. Petersburg in general. It's a team approach, and I'm happy to note it because, again, as Philip Filipovich used to say, it's a famous actor who used to say that in Bolshoi theater, people must sing. And if you are cleaning the floor, you do it outside. Although public cleaners may be good at singing. Maybe in Italy, the public cleaners are singing while cleaning. But this is not the point. Okay, thank you. Any other questions to our speakers? Okay, I have a question to the 3 speakers who made wonderful presentations. Taking the opportunity, I want to ask about how the 2 leading institutes, emergency hospitals, are working. Who is doing the balloon occlusion and mitral valve endovascular surgeries? Victor Reva should in our center. In our center, the head of vascular surgery unit is doing endovascular techniques. He masters all the methods, and also his team is doing some endovascular interventions and vascular interventions. So I would say almost everybody masters this method. Vascular surgeons do endovascular, and endovasculars do. Do you do balloon occlusion? Balloon occlusion, do you do it in traumas? Yes, we do in our center, but we use probably not the Rebo balloon. We use different other balloons of different arteries for clamming either iliac or arteries or popliteal. Well, as for Rebo, we don't use it in our center, for example, but all the other endovascular interventions are done by endovascular surgeons. They are on duty 24 hours. Thank you.
He has.
Здравствуйте, профессор из Бакуя.
Good afternoon. I have a question to Dr. Taka. How in Japan did you organize the hybrid ORs?
Hybrid OR in Japan.
How do we organize?
How do you organize the hybrid ER or hybrid OR in Japan?
So please give me more specific. So what do you mean organize?
Сколько гибридных операционных по всей Японии?
How many hybrid ORs are in Japan, and how can a hybrid OR help to the patient with traumas? I mean, not only in your center, but in Japan in general. this whole, is there a whole network of hybrid ORs in Japan, or there are some distinct separate centers?
As I answered in the last session, we have 11 trauma centers with using hybrid emergency room. So that means angio CT machine in the trauma resuscitation room, and perform all kind of examinations and treatment in the same place. That's the concept of the hybrid emergency room. And the effect of the hybrid emergency room may be like to shorten time to take CT scanning and for definitive surgeries, and so save hemorrhagic patients and probably like improve functional outcome of patients with TBI. And now we have organized the Japanese Association for Hybrid Emergency Room Systems in the last June. So we are trying to make like standardized treatment protocol in the hybrid emergency room. So we are trying to make it like make a publication in English. So if we wanted to, if you are interested in, please find out in several months later.
Such as transport.
Yeah, hopefully.
Hospital.
The question from him.
Yeah, sorry, a short follow-up to Japanese system. Do you, when you're planning your excellent system, do you do pre-hospital RIBOA for your paramedic teams? Do you simulate or train them specifically for pre-hospital?
The question, I think it should be answered by Yosuke. He has, he organized Japanese RIBOA study, so he...
In Japan, basically, the ambulance, the doctor do not get on the ambulance. Only limited hospital has the doctor ambulance system. So in that situation, some center try to implement a RIBOA or pre-hospital thoracotomy in field. But in Japan, as you may know, our patients are elderly population. So once we can get access, but sometimes we may encounter difficult to advance the catheter because of the tortuous or stenosed aorta. So if we compare the risk and the benefit of the pre-hospital RIBOA in Japan, probably the indication is very, very limited. We have small experience, but it's not so large. Probably the military pre-hospital is a very good indication, especially for the zone 3. But if we put zone 1, the balloon is making ischemia to the bowel. So, so far, we don't have a lot of cases in Japan, and probably the indication is very small, limited.
Please answer.
Good afternoon. My name is Jaime Tislado. I'm coming from Richmond, Virginia. Seems to me that the Japanese doctors are trying to take credit here of the hybrid room, and I'm glad to hear you have a lot of hybrid room there because you have lots of money. But the hybrid room is an old concept, has been in Europe for at least 15 or 20 years by Dr. Nicholson. He is the first one who developed this room in, I think, in Sweden or in England. And he has been pushing the idea of the hybrid room. The patient comes to the emergency room and they put the patient on the table with the cloth on. And as soon as they have the patient on the table, they get CT scanning in 30 seconds and the doctors are
Please,
right there.
your question, please. We have time requirement.
Oh, okay. My question is, well, I was making a comment, no a question. Thank you.
Thank you for the comment. So I would like to thank all the speakers and the panels. And as Dr. Kinoshita showed, hybrid ER is one of the ultimate solutions for EVTM world. But we can make the training to scan the patient as early as possible, and we can make the effort to read the image as early or as precise as possible. So the hardware is very important, but software is also very important. So I'd like to encourage it to implement EVTM concept in trauma or bleeding here in Russia. Thank you for the audience and panel speakers.
Спасибо всем докладчикам. У нас продолжается.
Thank you so much, dear speakers. We continue with poster sessions, and the posters are presented behind us. And now it's lunchtime and coffee break time. Thank you, everybody.